It's my great pleasure to be invited to present on one of the papers I'm writing on at the moment. It's based on an evaluation study we did last year, the end of last year. It's on the integration of the maternal and child health delivery system and the family planning service delivery system in China. As we all know, the MOH and the National Commission on Family Planning, they merged to become a new ministry. It's called the National Health and Family Planning Commission, as a result of a major public sector reform in March 2013. And this change actually has been introduced to the whole to the two systems at the same time, followed by the administrative reform. A resource integration policy has been issued out by the central government in late that year, 2013, defining the key principles and the requirements for resource and functional merge between the family planning centers and the maternal and child health organizations at various levels, from provincial down to the township level, so that divergent approaches and varied progress in different localities were supposed to be captured by some third-party evaluators. So at that time, we were invited to evaluate this policy implementation. And this is just a simple picture on the main actors depicted in the policy on the resource integration. And they just mentioned the three groups of actors. So national level, we have national government represented by the NHFPC, the new administrative agency on health and family planning affair. And also we have the state commission office on public sector reform, because this commission office is in charge of the personnel quota. As in China, we have a strict personnel registration system. So they think that this represents the main part of the resource. And at the local level, local government actors were identified. Provincial, city, county, and township level government, they are supposed to play a dual role in implementing this policy. And the service facilities, MCH centers at the various levels, and a family commission institutions were also identified. Quite straightforward steps are prescribed in the policy. So first, followed by the national guidance issued out on the integration of the resource. The provincial municipal government are supposed, and the county government are supposed to issue out their own guidance. So that is the detailed implementation plan for the policy. And then the detailed, the pragmatic implementation plan are supposed to be issued out by the township and the county level health authority, health and family planning authority, just as described by Louis in his presentation. This is a common way of policy implementation in China. And then actions by facilities, and then integration. We saw the integration, and then the evaluators come in to evaluate the results. So all seem to be straightforward and clear in a linear way. And here maybe you can find problems with this kind of straightforward way or naive thinking of the policy implementation described in the policy itself. But later on, please remember this line. Later on, you will find you were cheated by this simpleness. Okay, as I mentioned, a team of evaluators from my center, that's CNHDRC, and also some external policy experts recommended by the top health authority to join us to conduct the different field visits to 4 cities. Our main role is trying to identify the common problems and also the common innovative or very good outstanding innovative measures or mechanisms taken by the different sites. But, of course, this is a traditional evaluation program. But, after invited by Jerry to present on this, I reframed some of the findings we got from the evaluation study and around the narratives around innovation, change managing, or coping strategies to the reform. And then something new were found out. Okay, so the previous 3 questions are the traditional evaluation questions we got, okay. And the last one, actually, is what we're going to discuss in the next few minutes. Okay, the design, the methods of design is not strictly traditional type, because since 2010, I've begun to use this so-called developmental evaluation approach. This is very important because, after the evaluation of the essential drugs policy, I came into know this new theory, system theory, and complexity. And that theory is very helpful in framing a lot of issues, a lot of divergences you can find in the policy implementation in China. And so developmental evaluation basically is a kind of evaluation approach, trying to use the complexity lens as a way to interpret the divergency and the non-linearity of policy implementation. And also developers are no longer regarded as a neutral or, really at arm's length, from the program implementation itself, but more closer partners maybe with the program implementers at the local level, trying to fostering the learning process between the national and the local governments, and also various actors involved. Case study design, and this paper I'm going to write about mainly will draw from the data collected through the qualitative methods. That's key groups discussions with the government officials at various levels and also the service providers at different levels. So basically, a conceptual framework is supposed to develop, for this interpretation of the results. So still, I'm using the developmental evaluation as a, umbrella approach for understanding the whole things. And I emphasize on this double loop learning process because this is also stressed very much in the developmental evaluation. It involves dynamic and the system solutions, questioning the assumptions, policies, practices, values, and the system dynamics that led to the problems in the first place, and also intervening in ways that involve the modification of the underlying system-specific relationships and functioning. So I think this is very important, understanding for me to, understand the whole behaviors we noticed later on. So understand the policy design and implementation in the Chinese context. I think previous speakers have already touched upon all the things, concerning the uniqueness of having policy, implemented in China. And the policy usually, or social programs usually designed and implemented in an incrementalist way. That is, crossing the river by filling the stones at the river bed. This is a common way, approach economic and social reforms in China. And the so-called 3E models were noticed by some of the policy analysts, for example, like Jerry, he's done a paper on this together with Mr. Liu Yunguo. And they summarize the whole approach to policy implementation as a 3E, that is starting from experiment, that's formal or informal piloting in some local areas. And then the summaries of the experiences are expected to be done. And then some learnable or applicable lessons are supposed to be expanded to other localities. So each level of government play a dual role. For example, the central government, they are supposed to just flesh out what they are going to do with a central statement. That is a grand policy statements defined in the central policy initially. And then experiences are supposed to be summarized through some credited channels. And of course, implementation shall be done by various government or non-government actors together. And the results are supposed to be fed back to current policy implementation, as well as next round of policy-making process. Because this trend has become very obvious. So this kind of, no longer, this kind of evaluation is no longer regarded as a single loop learning that is focused on the current issues of policy implementation, but rather the central government are going to see what are the fundamental issues with the whole system that can be, taken from the local experiences that will, feed into the next round of policy making. So here, I argue for this point that, the central government in China or different level of government, they are beginning to see the significance of using double loop learning as approach to these kind of innovations at various levels. So here are some findings formed, framed under this, previously saying theories and also key terms. So first, of course, non-surprisingly, we found divergent, non-linear policy implementation in various localities with emergent behaviors of actors at different levels. 4 types of innovative measures observed. And these 4 types of innovative measures have also been summarized and presented to the Central Ministry after we finished the evaluation study. So first, we found that, very interestingly, the provincial government, they usually start some small-scale pilot or experiments before they really implement the policy at a province-wide, level. And also we found that, local government actors, they try to set up various level of government steering committee. So in this way, to crossing the barriers of miscommunications between different government agencies. Because the local government actors are not unanimous actors at all. They are formed by various agencies with various interests and powers. For example, some county government in one eastern province, they took the policy implementation as a chance to reallocate their health resources. They tried to build up a women and children hospital under the new merged MCH and Family Planning Center. It's quite interesting because obviously they had this agenda long before, but they took the chance, they jumped at the chance of the merge. And then we saw that the health and the family planning bureaus, they were weak. Most of them are weak in resource bargaining. And some of them suffered great loss in this merge process. And some individual actors, interestingly, they emerged to speak for their government organizations they belong to. For example, one DG of a county health bureau, they postponed the whole administrative reform just for his personal reason. He just wants to retain his post and retire on his post. So he postponed that. He spoke to me openly about this. He said that I'm old. I just like to be retired as a DG of a health ministry, a health bureau, rather than some, family planning or health bureau. And the same man, interestingly, he mentioned he had a very close relationship with a county mayor. That's a young girl, at her 33-year-old. And they discussed about the, resource merge and integration, so that, all things were put in correct place, for the resource integration. So very strangely, without administrative reform, the resource integration, completed. Very interesting. And also, he tried to bring out the right person at the right position. So only this single man, he decides a lot of things in that setting. And we observed some general coping strategy and measures. For example, like provincial and city government actors, they usually implement the policy with cautiousness as a way to cope with unknown outcomes. But for the county and the township government, most of them use the flexible policy implementation as a realistic way to buff repercussions of new policy. And this is very legitimate, if you think about how much resources were left, for the county and the township level government. They shoulder most of the responsibilities of the actual implementation of the policy, providing a lot of service to the community people. So they need to have this kind of realistic view of how to mitigate some negative outcome, but trying to amplify some positive ones. And we also saw innovative measures often designed for solving a specific issues in a unique context. So for us, some innovative measures may be there only of meaning, of some kind of significance in that specific context. For example, in Hubei province, in one of the pilot studies, the study sites, and they issued out some policy a decade ago. It's on the abolishing of the, they reformed the management of the personnel employed in the public institutions, including institutions like the township family planning centers, so that those, staff, they were no longer public employed staff. So this time, in order to take care of this group of people, they designed some unique policy around the integration of the resources, try to, saw a smooth transfer of those staff and merge into the new merged centers. And we also saw different ways to manage changes observed. And so most actors actively act upon changes rather than wait for the change to come. And also some actors created the changes themselves. For example, like the DG of that health bureau, he actively created some change and tried to, amplify his personal interests sometimes, And also passive or delayed response to change caused problems for some actors. For example, in Guangrao County of Shandong province, we saw that the health bureau, the head of the health bureau, were left out from the discussion around the, the policy decisions. So they have been, they are ignorant about the current, trends with the government. So the government decided, okay, we are going to set up a women and children hospital. And then he suddenly realized, oh, this is the case. And also the government, the county government decided to let the management power, transfer the management power of the township health centers to the hand of the township government. And this is also a very surprising, fact, because for the rest of the localities, we have never heard about such a decision happened. Maybe the county government just want to reduce some of the financial burdens of some sponsoring such, public institutions. But actually, this will greatly affect the service provision at the local level. So we can see that the health bureau at the county level in that county can almost be regarded as a loser in this policy bargaining. And another group of findings, another finding is evaluators facilitated the two-way learning process at multiple levels. And from the construct of our team to the, fields, you can see that we are semi-government, organization, a think tank of the Ministry of Health. Used to be the Ministry of Health, but now the National Health and Family Planning Commission. And some policy experts, the so-called policy experts, they were also designer of the resource integration policy, because they were, from various locations, and they participated in the design of the policy. By having these carefully selected people, you can see that the central authority just hope to see something else to happen. That's by collecting the data. They hope that maybe we can also disseminate the correct interpretation of the policy to various levels of government. And also, by having the focal group discussions with different levels of government, we try to have immediate feedback and comments on something innovative or not to the local government. In this way, we can help them to, shift their focus a little bit. For example, in Guangrao County, we commented one of our policy, specialists. He commented on the, establishment of the women and children hospital. He said that this is a terrible decision, because, basically you are trying to create some new, health resources introduced in this county that will have a lot of implications. And also this children's hospital, women's hospital, maybe you're going to invite the social capital to, join in. So this has become more hard and hard to manage, for you. So we jumped in to some of the local decisions in that sense. And we also behaved like messengers between multiple actors. Sometimes, you cannot imagine such kind of actors can be connected through us. For example, 2 months later, after our field visit to Guangrao County, some medical staff MCH staff called my mobile phone, telling me the news that, they as a group are going to be transferred to that Women and Children's Hospital together. And that they are no longer enjoy the full government subsidies. Part of their salary are going to be generated by themselves. They were complaining about this decision. They asked me if this is a correct policy understanding, and shall we report it to the upper level of government? I said, okay, it's not my role to tell you is it right or not. Please just report back to your government, local government, first county level, then city level, and then provincial level. Because basically this is, local policy are supposed to be implemented at a local level. So for me, maybe in my presentation to the central level authority, I'm going to mention this, okay, to raise attention from their side. So this is, you can see, very interesting, right? We're widening the knowledge pipe for the central decision makers in this way. And the double loop learning approach to policy design and implementation emerged. Very interesting. For example, you remember that very naive and simplified picture of the linear way of policy implementation? And you notice the main actors. The central government just, pinpoint several group of key actors, but leave a large areas of open space, for the local government to decide, to act upon. And now, after second thought, I think maybe this is, they are doing it intentionally, because after discussion with the policy experts, joined our visits to the fields, they also mentioned, when they were designing the policy together with the officials working in the NHFPC, they discussed about, the merge at the county and the township level are really thorny issues. Maybe here, we cannot, now we cannot decide a lot of details, but maybe later on, we can try to find out more. Because in different localities, obviously, different county and township government will have different, mentalities, and they know the best about the local situation. So let them to do it in some way, and then we generate some lessons. So very interestingly, and also the main purpose of having our evaluation is not trying to pick up the best performers, but rather to study the problems that of meaning to the whole system change. So in our contract with the central authority, they defined that our tasks as this, try to find the innovative measures and mechanisms and identify the common issues to all. So here you can find a double loop learning process. So not only concerned with the current issues of implementation, but also question the assumption of the policy and try to feed back to the next round of policy making. Very interesting. So since the paper hasn't been completed, so here I just got some rough, very rough conclusions here. I hope, you could, as experts, to comment on my, study, and I can get more insights. So basically, we saw a double loop learning approach employed by the health decision makers in China as a way to design and implement social innovations. And also, we think that more actors shall be watched closely for their responses or reactions to change, as well as the changes created by them. As mentioned by the central authority, the HFPC, where the previous evaluation is just a preliminary study on the effect. And maybe this year, we are supposed to take on another responsibility, commission research, and to evaluate some other pilots and try to, feed back to the policy implementation and also policy design process continuously. So evaluators or policy analysts actually, in this sense, can play a bigger role if they are cautious about their role and duty in a social innovation. That is, as policy analysts or evaluators, we are not, third-party evaluators standing out there collecting data and trying to, report back to the central commissioner. but rather we are deeply involved in the storytelling, in the local narratives about the policy, and also trying to forge some kind of learning pipe or knowledge pipe between different layers of the social structures, and also trying to convey some message and foster the changes. Okay, thank you.
First, in the beginning, I take place Fang Lingjie to give the presentation, but Fang Lingjie came. It's my pleasure to have opportunity to give the presentation here. My topic today is about expert participation in social policy innovation. Yue Xiao has introduced a model of the expert participation in policymaking. Maybe I will give another picture of how the expert participation in policymaking. Yes, from the models of policy innovation, maybe there will have some sophisticated models now. From internal determinants, from bottom up, the local areas have some new models, and then they will attract the central government and diffuse the models, and also the government diffusion models. Maybe the model is very good, and the other government maybe wants to learning from these good models, and this model will diffuse from more and more areas. These two kind of models is just a very, it's just a part of innovation models. And there are some scholars introduced the integrated in transition models. There are integration of the internal determinants model and government diffusion models. But before, except for besides this kind of models, what were the other policy engines? What are the policy innovation models maybe we ignored during the past years? In China, expert participation in policy innovation is more and more important, because in the government report there are some very official sayings that we need more and more scientific and democratic decision making, and improve information on decision making, and support intellectual systems. Also enhance the roles of think tank in policy making. We talk about many times of think tank. So under this atmosphere, the expert participation is very frequently in the past in the policy making, and the forms of the participation is also various. So you just talk about one form of the expert participation, when the central government made policy and the local government, according to the central principle, and then make their own plan for the policy innovation, and then invited the experts to involve in the policy evaluation, and then maybe a double loop in the system. But besides this, there are some other roles about the experts play in the policy innovation. And about besides this, I also want to talk about what action or strategy they could adopt it when participating in the policy innovation. And the third, maybe some are maybe successful and they're sustainable when they left it, and maybe some are failed. So what factors lead to the difference in the policy innovation with the expert participation? And for interpreted these topics, I want to take example we did several years ago. It's a pilot of the new rural cooperative medical system in Luochuan and in Shaanxi provinces. And the background of the pilot, why we did the pilot, because our policy research center followed the rural health reform for 10 years since 1999. So the health reform is our central concern during that years. And at that moment, it's just launched the new rural cooperative medical system. So there are many possible alternatives to push the new rural cooperative medical systems. So there is a policy window at that moment. And at that time, new rural cooperative medical system solved one problem, financing. Before the new rural cooperative medical system, the peasants, most of the peasants are not covered by any health systems. This kind of cooperative medical systems enlarge or improve capability of the possibility of the rural peasants involved in the system. But in the other developed countries, the health insurance also play another very important role, the third purchaser, because only the social security is not enough, because it's asymmetric information in these areas. So the individual peasants maybe didn't have the enough mission to make decisions or bargaining with the health provider. So, but you know, as NRCMS didn't take function at that moment, even at the moment, it's still problems unsolved. So this is the core problems we think at that moment. So the pilot initiated by the Social Policy Research Center and supported by the county government and township government, sponsored by the FID and MIT Foundation. It's an external policy initiative by the Social Policy Research Center. This is the nature of the pilot. It's not from the government, the local government, it's from a research center. And the basic situation of the pilot in 2004, the county is an actual county. You know, it's next to the Yan'an city. Yan is revolutionary base in the revolutionary phases. But after that, it's become very poverty areas around these places. And the pilot area, Luochuan, is one of the poverty county in that areas. The population is 220,000, and you know at that moment the per capita income of peasants is about $250. It's very poor comparing to the national level, and the coverage rate of the NCMS is about 6%. It's 6.7%. It's less than 7%. So you can see most of the peasants are not covered by any health insurance, and the health expenses is a very big problems, especially in those areas. So the objective of the projects, there are four objectives. First, to build a new primary health services. Why we propose that? Because at that moment, the NCMS the target is to the big illnesses expenses. It didn't cover the many illnesses. So we want to propose a new model to cover the cost of the many illnesses cost. The second, build a supervision system in rural township level. Just now, I said the NCMS didn't take the roles of the supervision or the third purchaser. So in our imagine, we want to build a peasants medical cooperative association. It's from bottom up. It's just based on the association's power to supervise the induced over supply. And the third is cultivate the balance mechanism and the synergetic mechanism between the supplier and demander. The fourth, construct a basic governance structure for rural primary health care. And this is the four objectives in the beginning. And the pilot is in two phases. The first phase is establish a policy framework, and also build some institutions and also organizations. This framework is the institutions we use of the local resources. The upper level is the community health service center. It's based on the township hospital and build this health community health service center. And in the lower level is the health service station. It's just employ some village doctors involved in the system and give salary to them to take the responsibility of to give some primary service to peasants. And this is very important framework, policy framework we designed first. You can see in the original framework of the primary health care, there are no this township council. It's no representatives from the peasants. This is two things we did. The representatives is just from the peasants, from different villages. They democratic elected the representatives from each villages, and they will represent the interest of the peasants to bargaining with the township NCMS and bargaining with the community health service center. And this is a township council. It's like the government steering council, just Xiao talked about. Because when you make a pilot, you need a council or committee to guide how to implement it, the pilot. So, and one thing in China you should know, whether or not the pilot will running smoothly depending on the focus of the county leaders. If he will responsible for the pilot, it will move smoothly. If he not, it may be failed. So the township council is very important in this framework. And the payment, firstly, it's using the external fund. Is from the Amity Fund to financing for this package for this pooling. And then after back to this normal, the peasants should financing themselves for their primary health care. And so you should see in this picture, it will achieve 3 targets: is collective financing, collective bargaining, and collective collective bargaining, collective financing, and the peasants voluntarily involved in this framework. They can have opportunity to negotiate with the suppliers. This is the most important thing. We think they can play supervision roles. And the township NCMS council, this is what it is elected representatives, 24 representatives. And the village leaders is also representatives, 6 representatives. And the upper level is the director of the township NCMS. This is the 6th village we elected for the pilots. And the second phase is policy innovation practice. I didn't see the very detail of have time to describe the very detail of policy innovation practice. I just list some key events when to running these pilots. In 2004, the CAS sent an official letter to Provincial Health Authority, obtaining consent from the Provincial Health Authority. So, and 2000 May, the township undertook director of the township council. It's the government steering committee. And the local government and local authorities accepted the democratic elections for NCMS representatives. Until 2004, the deputy minister of MOH at that moment visited the pilot, invited our research team for talks, and wants to think our ideas about how to push forward the reform of the NCMS. And then in 2004, the Credit Bureau of MOH, the Chinese Medicine Council, and the Provincial Health Authority visit pilots. And then in 2005, the financing shifted from external support to peasants themselves. It's back to a normal financing base. And in 2005, the Asian Development Bank decided to support the pilot. So you can see from these key events, it seems it's running very smoothly. Firstly, it's get the consent from the upper level government. When the upper level governments agreed it, the local levels will cooperate it and will implement it, the pilots. But in the end, the county level government is not interested for continued project, and the township hospital quit program. Why it is, I will explain later. So you can see from this process, the experts of the participation in the policy making is the initiative from the framework is designed by the Social Policy Research Center based on their past experience, and they want to, especially to set up a supervision committee and a representative the peasants is the most motives. And they use their academic status, national academic status, because they had authority to speak to the central government, and they get consent of the PHA. And then they can push the local government to cooperate it. This is the things they can do. But in the end, they can't push the local government to cooperate it in the end. So you can see what was the reason for this. The characteristic for policy innovation, just I talk about a little bit. It's a neutral, independent policy actors. We didn't the interest groups in the local level. We're not the health bureaus. We're not the upper level governments. We're just independent policy actors, and it's a top-down process. It is supported. Firstly, I just said key events. You can see it's supported from the central government's ministries, MOH, and the provincial health authority came before the pilot, and then the pilot are running. So it's like a top-down process, and it's external to internal policy experiment. It's not generated from the bottom. It's the design of the policy is from the social policy studies. It's embedded in the social structure of the local society. So there is a threat in this. Whether or not the local society can know or accept it in their policy, know the policy, and then when the when this social policy research center left this pilot, whether or not they can move on to continue to the pilots, it's a problem for this. And the fourth is the economic support is from external fund. When it's back to normal to financing based on the peasants themselves, it has problems. Some peasants are not interested in this program. They want to involve the other program. It has also problems here. So the bulk policies, the bulk conditions, we can see some advantages of the experts involved in the policy participation. But is it enough for the policy innovation? I want to say whether or not the bulk conditions are sufficient for the sustainability of policy innovation. What factors missed in the case of pilot failure and the Chinese background? You can see in the last, the county government quit, and the township hospital don't want to move on the pilots. The direct cause, because the interest of the township hospital was severely affected, because we designed the price of the medicine is lower than the normal level. At that moment, most township hospital, though it's non-profit, it's a public organization, but it's will depending on the the medicine profit for survival in the market. So when this when this community service center built it will attracted more and more peasants here. So the interest of township hospital was severely affected. And then the county government realized the potential burden on local budgets. They should cover the salary of these officials. And then these two kind of actors are set up a position coalition. They both resisted to put forward of the innovation reform. And I think this is just a direct cause of this failure of the pilots. But you can see the indirect cause of China. When you make policy innovation pilot, even you get the consent from the upper level government, from the provincial government, they didn't have the resist suggestion or some things. Maybe there are indirect causes and more important causes. Is because of the decentralization of the governance. The local government is the key factor to make any pilots here, because the financing from the local governments, the personnel from the local governments. So this is the most important in any pilots in China. And I think there is a policy game here. The embeddedness of policy actors. The local policy network is strong embedded, and external policy networks is weak embedded. We all, the researcher, the upper level or the central level government is the weak embedded. So there will some results in the end. Some embedded loser, they will lose their interest after the pilots. And maybe some benefit embedded beneficiaries. They will not resist. And there are some neutral actors. And what will cause the, what will, how to say, guide or lead to the result of the pilot? I think the most important is embedded loser. If they realized it will hurt their interest, they will, especially in the position of some high officials, they will, or some key bureaucratic positions, they will set up a coalition to resist it, the pilots. So there was some more discussion. The local policy innovation is dynamic and a complicated decision-making process. I think Xiao Yue will draw a picture is very interesting, very interested, and very so many materials. Maybe in the first they will agree, and then they will choose another way, because there are complicated political performance or the other things in the process. And the second thing is the local leader is very important in policy innovations. Whether or not to push the pilot or spread it pilot or give financing a budget pilot, it's not from the upper level, it's the local level. And the third, expert participation. Just now, Xiao Yue gave a picture of how the expert participation, evaluation, and then they will give a suggestion to the central government, maybe give a improved version of how to improve the policy, and then the local governments will, based on this policy, to make new plan. This is a loop of, yes, I think most of the expert participation is this style. But I think there is another active innovator, like what we did, and it's failed, sadly. But I think these two kinds of expert participation have two kinds of threats. For the first, you know, in China, it's a centralized political system. And we say, some experts said it's a championship political system. So the local governments wants to make the political achievements to attract it, to get promotions. So especially after 2009, because the direction of development from economic development to the social development, they want to make the pilots to attract the budget, to attract it, the central government. So they want to the experts to be the transfer agents to like this. We also play these roles. But whether or not this kind of pilots is useful for spread is valuable for spread the experience, because when it's set up the pilots, it will invest in money at any cost, because it wants to be a political star or anything like that. So whether or not it's valuable for its further spread, this is the problems here. And the second is the active innovator, like we did during the past years. Yes, we have our ideas. Maybe it's from our past experience, and maybe it's scientific, but whether or not it's suitable to the local areas, and whether or not the local community have the capability to accept it ideas and to become their own routines. You can see in our pilot, the peasants, we want to build up voluntary medical associations to take the function of supervision. But the peasants themselves didn't have the capability to supervise. So it's also one of the reasons to fail. So this is, I think there are two different fronts, the threats in the policy participation. And maybe I also interested was the expert participation in the England, in the USA or in the other countries is also very interesting for me. Okay, thank you. This is my topic.